Dysphagia is defined as any difficulty in swallowing affecting any part of the swallowing pathway from the mouth up to the stomach. So any difficulty in swallowing is dysphagia, and it is very important. Why? Because more than 50% of the cases of dysphagia are coming to ear, nose and throat clinics, and we as otolaryngologists should know how to diagnose a case of dysphagia and to decide which all cases we have to treat and which all cases we have to refer to a gastroenterologist, to a neurologist or to an esophageal surgeon. So the causes of dysphagia and the investigation needed for the diagnosis of dysphagia I am going to describe today. And before knowing the causes of dysphagia, you have to be thorough with the physiology of swallowing, which was already given in an earlier class. Okay. So another term also you have to know is odynophagia, and this odynophagia is painful swallowing. In a case of tonsillitis, pharyngitis or even an aphthous ulcer of the tongue will cause painful swallowing, and that is called odynophagia. Coming to the causes of dysphagia, there are so many classifications on causes of dysphagia. The one popularized in general surgery series by Ellis is into local and general causes, which is applicable to all obstruction to the all lumen in the body, like diseases in the lumen, diseases in the wall and also external causes. But in ENT, the standard textbook, especially the Scott Brown textbook of ENT, is giving the classification of dysphagia as congenital and acquired causes. So we will go after that. Okay. So these are the causes of dysphagia. Can be divided into congenital and acquired. Under congenital, and in congenital, most of the cases of congenital problems will present early in life, and only a very small percentage of cases will be presenting later in life. Okay. So diagnosis will be easy as it presents in early life. So one is choanal atresia, and this choanal atresia can be partial or complete. Partial choanal atresia usually present as feeding difficulty because these neonates are obligate nasal breathers and there will be problems with the sucking. And complete choanal atresia usually present with a respiratory difficulty, and they are diagnosed by absence of air, passage of air through the nostril and inability to pass nasal catheters, and also it is confirmed by an axial CT scan after decongestion of the nose. So that is about choanal atresia. Cleft lip and cleft palate can also present as dysphagia, and another one is laryngomalacia. Most common cause of stridor in the first year of life associated with dysphagia is laryngomalacia. Okay, and this is usually diagnosed in the outpatient using a nasopharyngoscopy, or it can be diagnosed under general anesthesia with the direct laryngoscopy. Unilateral vocal cord paralysis present with the difficulty in swallowing associated with the hoarseness and aspiration, whereas bilateral vocal cord paralysis usually present with the stridor. Okay, and again this is can be diagnosed in OPD using a flexible nasopharyngoscope. Laryngeal cleft can also present as difficulty in swallowing, and the management and the degree of dysphagia depending upon the type of laryngeal cleft that we can discuss after this. Also tracheoesophageal fistulas, esophageal atresia, vascular rings. Vascular rings are disorder caused by anomalous vascular compression or anomalous blood vessels, and it will also may be a cause of dysphagia. So these are the some of the commonest causes of congenital dysphagia, and in acquired condition we can again divide into traumatic, infective, inflammatory associated with esophageal motility disorders due to neoplasms, then neurological causes, drug induced because of aging and miscellaneous. And in the traumatic causes, trauma to the head, neck, chest and cervical spine can present as dysphagia. It can be accidental or iatrogenic, something related to treatment or surgeries, or can be due to blunt trauma, or can be due to direct injury and cranial nerve palsy, especially damage to 9, 10, 11 and 12, 9 to 12 cranial nerve. And head injury is also one of the commonest cause of an dysphagia. And in the infective causes, the infection can be anywhere from mouth up to the stomach. So, in the oral cavity, oropharynx, common acute pharyngitis, tonsillitis and quinsy. Then glandular fevers caused by Epstein-Barr virus, which is associated with, along with the dysphagia, there will be severe cervical lymph node enlargement also. Then acute supraglottitis, again present with the dysphagia. Then herpetic fungal or cytomegalovirus causing mucosal lesions leading to dysphagia. Candidiasis of the oral cavity and also the esophagus, tuberculosis and neck abscesses like retropharyngeal abscess, parapharyngeal abscess or submandibular abscess. All these will lead to, these are the infective causes for dysphagia. And what are the inflammatory causes? Under the inflammatory comes, the commonest one is GERD, gastroesophageal reflux disease, in which the patient may present with a the complaint of foreign body sensation in the throat, and something the patient will tell as something moving on from here and there in the inside the throat, or there can be retropharyngeal retrosternal pain, can present with even with earache or tinnitus, feeling of pressure in the ear. The multiple vague complaints associated with the swallowing will be there in a patient of GERD, and if it is progressive, there is chance of a stricture formation. Also, another inflammatory cause is Patterson-Brown-Kelly syndrome or Plummer-Wilson syndrome. It is also important. Then systemic autoimmune disorders like scleroderma, Crest syndrome or dermatomyositis. Then SLE, systemic lupus erythematosus. Multiple connective tissue disorders, rheumatoid arthritis, and in esophageal motility disorders mainly comes is achalasia cardia, diffuse esophageal spasm and nutcracker esophagus. All these are important in theory and also in clinical under esophageal motility disorders. Under neoplastic conditions, neoplastic lesions can be either benign or malignant tumors from the lip, from the skull base up to the diaphragm. Okay, so it can be benign tumors of the oral cavity, pharynx or esophagus, or it can be malignant tumors of esophagus, oral cavity, pharynx and esophagus. Then it can be an esophageal carcinoma or any tumors of the skull base, or it can be leukemias and lymphomas, or it can be enlarged mediastinal lymph nodes. So all these comes under neoplastic lesions. Then in neurological, cerebrovascular accidents or the stroke is probably one of the commonest cause of a neurological cause for dysphagia. It can be in the cortical level or at the corticobulbar level causing a pseudobulbar palsy, or at the level of the bulbar nerve nuclei causing a bulbar palsy. But in majority of cases, the recovery from dysphagia happens within the first week of this stroke. Or it can be due to an isolated neurological causes. Isolated recurrent laryngeal nerve palsy or Parkinson's disease or multiple sclerosis, myasthenia gravis or motor neuron disease. All these can cause dysphagia. So the drugs causing dysphagia we can divide into those causing esophagitis, or as a part of normal pharmacological action as inhibitory drugs and excitatory drugs, or as a part of normal side effect, that is drugs complications. In esophagitis, the drugs causing esophagitis mainly because the drugs are taken without adequate water or drugs taken just before going to bed. And during sleep, the esophageal transit time is prolonged. So that what happens, these drugs will come in contact with the mucosa directly, Without adequate mixing with saliva, it can cause problem in the mucosa. And also the most commonly affected part is at the level of crossing of arch of aorta. And the drugs mainly causing this are tetracycline or doxycycline or vitamin C or broad spectrum antibiotics or chemotherapeutic agents. All these are the stands of causing esophagitis. Inhibitory drugs like tricyclic antidepressants, then anticholinergics, then calcium channel blockers. This will cause inhibition, that is decrease the tone of lower esophageal sphincter, and also the esophageal peristalsis is reduced. Thereby it will cause dysphagia. Excitatory drugs like cholinergic agonist, then metoclopramide, then cisapride. They will increase the esophageal emptying. They will fast increase in the or rapidly cause esophageal emptying is made rapid, and also gastroesophageal reflux is increased. So there can cause dysphagia. And the side effects of drugs like antihypertensives, ACE inhibitors, opioids, etc. They also cause xerostomia and also will cause dysphagia. So all these drugs, they are the drugs causing esophagitis, inhibitory and excitatory drugs, and also as a side effect of drugs, mainly because of xerostomia leading to dysphagia. Then aging related to dysphagia, that is presbyphagia, which was already explained in an earlier class. Then under miscellaneous, these causes may be due to foreign bodies in the pharynx or in the esophagus, or it can be due to caustic strictures of the esophagus, or pharyngeal pouch, which I already explained. Then globus pharyngis. Globus pharyngis is a feeling of lump in the throat, mainly seen in a middle-aged, more common in middle-aged females. And the typical history is there is difficulty while swallowing saliva, and there is not much difficulty in swallowing food. That is the most striking history towards a globus pharyngis that I will explain in detail. And patients in tracheostomy. Why there is dysphagia in patients of tracheostomy? Because the elevation of the larynx while swallowing is interfered by doing a tracheostomy, and also if there is a cuffed tracheostomy tube and the cuff is overinflated, again that will cause dysphagia, and also thyroid disorders. So these are the causes of dysphagia, which we can divide into congenital and acquired. Acquired again under these 9 subheadings, so that you should be thorough. And how can we come to a diagnosis of dysphagia? What is the cause of dysphagia? So you should be thorough with the causes leading to dysphagia, and you should go with a detailed history of the patient. So diagnosis starts with getting a detailed history, and after that clinical examination including indirect laryngoscopy or flexible laryngoscopy, and also there are some special investigations. So we can go through that.